Nursing and midwifery tropical medicine. Tropical medicine. Introduction. Diseases can be divided into a few large groups according to their main causes. Most of common diseases in Africa are due to infections by living organisms, viruses, bacteria, fungi, chlamydia, rickettsia, and protozoa. These are called communicable diseases because they spread from person to person or from animal to person. Together with malnutrition, they are today the major cause of illness in Africa. The communicable diseases occur at all ages but are most serious in childhood due to intensive exposure and poorly developed immunity. These diseases are to a large extent preventable in countries where they have been prevented. Other conditions such as accidents and the degenerative and malignant diseases which occur, mainly at old age, have taken their place and become the commonest. Why are communicable diseases important in Africa? Oh, many of them are very common. Oh, some of them are very serious and cause death and disability. Oh, some of them cause widespread outbreaks of the disease epidemics. Oh, many of them are preventable by fairly simple means. Oh, many are particularly serious and more common in infants and children. Organisms and agents of disease. The living organisms that cause communicable diseases are of different size and sorts. The largest, like tape or filariae worms, are visible to the eyes. They are made of many cells and are called metazoa. Complicated but single-celled organisms like malaria parasites and amoeba are called protozoa. They are smaller and can only be seen when magnified with a microscope. Smaller still are bacteria, which are simple, single-cell, best seen under a microscope after they have been stained with dyes. Rickettsia and chlamydia are smaller and can only multiply within cells. Smallest of all are the viruses. These cannot be seen with an ordinary microscope. Patterns of communicable diseases. Nursing and midwifery tropical medicine. The agents need a suitable environment in which to grow and multiply and must be able to spread and infect other hosts. If they do not succeed in doing this, they die out. There is therefore a balance between the agent, the host, and the environment, which can change and be made to change in different ways. Environment. Agent host. Host people are affected by environment. For example, they may live in a hot climate in which there are many mosquitoes. But people can also change this environment by draining swamps, changing the vegetation, and adding competing hosts such as animals. Similarly, the environment can affect the agent, for example, the altitude and the temperature for malaria. Terminology. Infectious disease. An infectious disease is an illness due to a specific infectious agent or its toxic products that arise through a transmission of that agent or its products from an infected person, animal, or reservoir to a susceptible host, either directly through an intermediate plant or animal host, vector, or inanimate environment. Infection. Infection is the entry and development of an infectious agent in the body accompanied by an immune response. Disease. Manifestation of infection through symptoms and signs. Exposed. Someone who has met with an infectious agent in a way that is known to cause disease. Colonization. Colonization is the presence of a replicating microorganism without clinical or subclinical infection or disease. No immune response. Carrier. Carrier is a person that harbors a specific infectious agent in the absence of clinical disease and serves as a potential source of infection. Nursing and midwifery tropical medicine. Reservoir. The reservoir of infection is the animal or place in which a particular organism usually lives and multiplies. Most of the important communicable diseases humans are the main reservoirs. Route of transmission. The route of transmission is the way in which an organism leaves the infected host or source and travels to a new susceptible person. Source. The source of infection is the animal or place from which the particular organism spreads to its new host. Incubation period. The incubation period is the time between infection and the appearance of signs and symptoms of illness. Epidemiology. Epidemiology is the study of the distribution and patterns of health events, health characteristics, and their causes or influences in a well-defined population. Or, it is a branch of medicine that deals with the study of the causes, distribution, and control of diseases in the population. Endemic. It means the disease is present in a community at all times, but in a relatively low frequency. Something that is endemic is typically restricted or peculiar to a locality or region. For example, malaria is endemic in some areas of Africa. Epidemic. An epidemic is a sudden severe outbreak of an infectious disease that spreads rapidly within a region or group affecting a large proportion of people. Pandemic. A pandemic occurs when an epidemic becomes widespread and affects a whole region, a continent, or the entire world. Clinical disease. A clinical disease is a disease which has physical manifestations, clinical signs, and symptoms. Susceptible hosts. Nursing and midwifery tropical medicine. In some cases, humans may be the only hosts, in which case the infection spreads directly from person to person, e.g., measles. In other cases, humans are the final hosts from whom the organism has no chance to pass further, e.g., tetanus. There are 3 parts of a transmission cycle for an agent or organism. Source transmission, susceptible hosts. Source. The source of an infection can be an infected person or animal or soil. People and animals may have clinical disease, subclinical disease, or be carriers. Transmission. The main routes of transmission are direct contact, skin, mucous membrane, sexual intercourse, vector transmission, fecal contamination of soil, food and water which are ingested, contact with animals or their products, e.g., biting, airborne transmission, inhalation, transplacental mother-to-child transmission, blood contact injections, surgery, blood transfusion. Susceptible hosts. A susceptible host is one with low resistance to a particular infection. Low resistance may be due to black small square, not having met the organism before and therefore not having any immunity to it. 4. Example, at the age of 6-12 months, a child loses the passive immunity against measles, which was acquired from the mother during pregnancy. When in contact with another child who has measles, the child will develop the disease because of no immunity against measles. Black small square. Having another serious illness like AIDS at the same time. Such people have a higher risk of developing tuberculosis. Black small square. Malnutrition which can make the infection worse. Principles of communicable disease control and prevention. The aim of control is to tip the balance against the agent. This may be done by attacking the source, interrupting route of transmission, protecting the host, attacking the source, interrupting transmission, protecting the host, treatment, environmental sanitation, immunization, isolation, personal hygiene, chemoprophylaxis, reservoir control, vector control, personal protection, nursing and midwifery tropical medicine, gastroenteritis GE. Introduction. Gastroenteritis is a medical condition characterized by inflammation of the gastrointestinal tract that involves both the stomach gastra and the small intestine interior, resulting in some combination of diarrhea, vomiting, and abdominal pain and cramping. The severity of infectious gastroenteritis depends on the immune system's ability to resist the infection. Electrolytes, mainly sodium and potassium, may be lost as the infected individual vomits and experiences diarrhea. Cause 1. Viruses. Rotavirus, norovirus, adenovirus, and astrovirus are known to cause viral gastroenteritis. Rotavirus is the most common cause of gastroenteritis in children. Norovirus is the leading cause of gastroenteritis among adults, causing greater than 90% of outbreaks. 2. Bacteria. In the developed world, Campylobacter jejuni is the primary cause of bacterial GE. Escherichia coli, Salmonella, Shigella, and Campylobacter species. Salmonella is contracted by ingesting the bacteria in contaminated food or water and by handling poultry. Campylobacter occurs by the consumption of raw or undercooked poultry, meat, and other foods. It is also associated with unpasteurized milk or contaminated water. Nursing and midwifery tropical medicine. A number of protozoans can cause gastroenteritis, most commonly Giardia lamblia, Entamoeba histolytica, Cryptosporidium. 4. Non-infectious causes. Medications like NSAID. Certain foods such as lactose in those who are intolerant. Crohn's disease. Transmission. The germs are spread through feces or vomitus of someone suffering from the infection. Gastroenteritis spread by drinking untreated or unboiled water from rivers, streams, lakes, ponds, and unprotected springs. Eating cold food which is exposed to dust, flies, or cockroaches. Not washing hands with soap and water after using a latrine. Eating unwashed fruits and vegetables. Serving foods and drinks in dirty containers. Keeping drinking water in dirty containers. Poor disposal of feces. Open rubbish in compounds which attract flies and cockroaches. Signs and symptoms. The main symptom is diarrhea, often with vomiting as well. Blood or mucus can appear in the stools of an infected person. Crampy pains in the abdomen are common. Pains may ease for a while each time you pass. Some diarrhea. Low-grade fever, headache, and aching limbs sometimes occur. Symptoms of dehydration. Nursing and midwifery tropical medicine. Diagnosis. Gastroenteritis is diagnosed clinically based on a person's signs and symptoms. Stool cultures should be performed especially in those with blood in the stool. Management. Gastroenteritis is usually an acute and self-limiting disease that does not require medication. The preferred treatment in those with mild to moderate dehydration is oral hydration therapy or intravenous delivery may be required if there is a decreased level of consciousness or if dehydration is severe. Plain water may be used if more specific and effective ORT preparations are unavailable or are not palatable. A nasogastric tube can be used in young children to administer fluid if necessary. Institute fluid balance chart. Metoclopramide may be helpful in some children, and butylscopolamine is useful in treating abdominal pain. Fermented milk products such as yogurt are similarly beneficial. Zinc supplementation is effective in both treating and preventing diarrhea among children. Antibiotics are not usually used for gastroenteritis, although they are sometimes recommended if symptoms are particularly severe or if a susceptible bacterial causes. Nursing and midwifery tropical medicine. Prevention and control. Black small square. Always wash hands with water and soap before preparing, serving, or eating food. Black small square. Always wash hands with soap and water after using a latrine. Black small square. Always boil all drinking water or treat with chlorine. Store it in a clean container. Black small square. Eat food when still hot. Black small square. Foods eaten raw such as fruits and vegetables should properly be washed and where possible peeled before eating. Black small square. Cover all foods to avoid contamination by dust, houseflies and cockroaches. Black small square. In case a person dies of diarrhea, report immediately to the health authorities. Black small square. Kill the germs by sprinkling germ-killing solutions such as JIK on stool or vomitus and all other materials used by the person suffering from diarrhea. Black small square. Nursing and midwifery tropical medicine. Cholera. Definition. Cholera is an infection of the small intestine caused by the bacterium Vibrio, characterized by profuse watery stools, vomiting, dehydration, and collapse. Cause. Cholera is caused by the bacterium Vibrio cholerae. This bacterium is gram-stain negative and has a flagellum, a long projecting part for motility, and pulley hair-like structures used to attach to the tissue. Transmission. Cholera is primarily transmitted by the fecal contamination of food and water caused by poor sanitation. The source of the contamination is typically other cholera sufferers when their untreated diarrheal discharge is allowed to get into waterways or drinking water supplies and eating any food wash in contaminated water. Cholera is rarely spread directly from person to person. Susceptibility. About 100 million bacteria must typically be ingested to cause cholera in a normal healthy adult. Children are also more susceptible, with 2 to 4 year olds having the highest rates of infection. Persons with lowered immunity, such as persons with AIDS or children who are malnourished, are more likely to experience a severe case if they become infected. Pathophysiology. When Vibrio cholerae is consumed, most bacteria do not survive the acidic conditions of the human stomach, but there are always few surviving bacteria. When the surviving bacteria leave the stomach and reach the small intestine, they need to propel themselves through the thick mucus that lines the small intestine to get to the intestinal walls. Nursing and midwifery tropical medicine, where they can survive and multiply. The bacterium has flagella for mobility and the pulley used to attach to the intestinal tissue. Vibrio cholerae produce a toxin which causes the most severe symptoms of cholera. The toxin produced is an enterotoxin. The enterotoxin causes human cells to extract water and electrolytes from the body, mainly the upper gastrointestinal tract, and pump it into the intestinal lumen where the fluid and electrolytes are excreted as diarrheal fluid. Signs and symptoms. The incubation period is thus usually 2-3 days. In a typical case of severe cholera, the disease develops in 3 stages. Stage I. Profuse watery stools pour from the patient. Soon fecal matter disappears from the stools, which become almost clear fluid with flakes of mucus, giving the classical rice water appearance. Vomiting follows the diarrhea. At first, food is vomited, but soon only rice water is vomited. Severe cramps in the abdomen and limbs develop from salt loss. Stage Roman II. In the second stage, there is dehydration and collapse. The body becomes cold, the skin is dry and inelastic. Nursing and midwifery tropical medicine. History taken from the patient and relatives, observing the characteristic rice water. Diarrhea. Stool analysis, stool culture, fresh stool or rectal swab. Polymerase chain reaction PCR to detect the genetic material. Prevention. Although cholera may be life-threatening, prevention of the disease is normally straightforward if proper sanitation practices are followed. Black small square. Always wash hands with water and soap before preparing, serving, or eating food. Black small square. Always wash hands with soap and water after using a latrine. Black small square. Always boil all drinking water or treat with chlorine. Stored in a clean container. Black small square. Eat food when still hot. Black small square. Fruits eaten raw such as fruits and vegetables should properly be washed and where possible peeled before eating. Black small square. Cover all foods to avoid contamination by dust, house flies, and cockroaches. Black small square. In case a person dies of cholera, report immediately to the health authorities. Burial should be immediate. Avoid serving food. Black small square. Surveillance and prompt reporting allow for containing cholera epidemics rapidly. Black small square. Kill the germs by sprinkling germ-killing solutions such as JIK on stool or vomitus and all other materials used by the person suffering from cholera. Black small square. Improvement of water and sanitation to reduce transmission of infection. Black small square. Investigations of diarrheal outbreaks. Black small square. Immunization with cholera vaccine. Black small square. Treatment of malnutrition. Treatment. The patient can be admitted to temporary hospital, a school, or church. The patient is admitted on a cholera bed with a central hole through which the continuous stools pass into a calibrated bucket containing a disinfectant. Nursing and midwifery tropical medicine. First 24 hours of treatment. Switch to ORS solution if hydration is improved and the patient can drink. A nasogastric tube can be used in young children to administer fluids if necessary. Antibiotic, doxycycline 300 or ciprofloxacin single dose. These drugs are contraindicated in pregnancy. Instead use Cetrin. Child, cotrimoxazole or doxycycline or ciprofloxacin or erythromycin. Give dextrose IV for hypoglycemia. Zinc supplementation is effective in both treating and preventing diarrhea among children. Isolation of patients to prevent spread of infection. Stools and vomit are specifically infective. Proper disposal of stools and vomitus into a pit latrine. Hospital equipment should be cleaned with a disinfectant such as JIK. Instruments can be cleaned with JIK or sterilized. Institute a fluid balance chart. Complications. Electrolyte imbalance. Nursing and midwifery tropical medicine. Bacillary dysentery shigellosis. Bacillary dysentery is an acute bacterial disease involving the large and small intestine, characterized by bloody mucoid diarrhea. Bacillary dysentery should not be confused with diarrhea caused by a bacterial infection. 1. Characteristic of bacillary dysentery is blood and stool, which is a result of invasion of the mucosa. The pathogen. Cause. Shigellosis is caused by one of several types of Shigella bacteria. Shigella sonnei, Shigella flexneri, Shigella dysentery. Mode of transmission. Bacillary dysentery is transmitted directly by fecal material of a patient/carrier or indirectly through contaminated food and water. Infection may occur after consuming a small number of the germs. Therefore, chance of spread among household members or in institutions can be very high. It occurs more commonly amongst young children. Clinical features. Incubation period is usually 1-3 days, but can be up to 7 days. Sudden onset of mucoid bloody diarrhea. Fever. Nausea or vomiting and abdominal crumbs. Tenesmus sensation of desire to defecate without production of significant amounts of feces. Flatulence passing gas. Headache and fatigue. Dehydration. Diagnosis. Nursing and midwifery tropical medicine. Fresh stool is collected for culture and sensitivity microscopy. Management. Admission on a medical ward in isolation. Personal hygiene should be observed to avoid infecting other persons. Barrier nursing. Disinfection of bed and other items used on the patient. Proper disinfection and disposal of fecal matter and vomit into pit latrine. Observations of TPR, BP hydration level, LLC. Reassurance of patient and relatives. Dysentery is initially managed by maintaining fluid intake using ORS or intravenous fluids if there is severe vomiting and diarrhea. Investigations. Fresh stool is collected for culture and sensitivity microscopy. Nalidixic acid 1/6 hourly for 5 days or ciprofloxacin 1g single dose. Brat diet, i.e. bananas, rice, applesauce, toast. If patient vomiting everything, a nasogastric tube is passed for feeding and drugs. Medication for nausea and vomiting, metoclopramide plaza. Monitor hydration levels and maintain a fluid balance chart. Prevention. Keep the premises and kitchen utensils clean. Dispose rubbish properly. Keep hands clean and fingernails trimmed. Oh, wash hands properly with soap and water before eating or handling food, and after toilet or changing diapers. Oh, drinking water should be boiled or treated. Oh, avoid high-risk food like shellfish, raw food or semi-cooked food. Oh, wear clean, washable aprons and caps during food preparation. Oh, clean and wash food thoroughly. Scrub and rinse fruits in clean water. Oh, store perishable food in refrigerator well covered. Oh, cook food thoroughly. Oh, consume food as soon as it is done. Nursing and midwifery tropical medicine. Oh, exclude infected persons and asymptomatic carriers from handling food and from providing care to children. Amoebic dysentery, amoebiasis. Amoebic dysentery is a common parasitic infection of the gastrointestinal system acquired through oral fecal contamination. Causes and transmission. Amoebic dysentery is caused by the parasite Entamoeba histolytica found in contaminated food and drinks. Amoebic dysentery is transmitted through contaminated food and water. Amoebae spread by forming infective cysts which can be found in stools and spread if whoever touches them does not wash their hands. Symptoms. Violent diarrhea, often accompanied with blood and slash or mucus in the foul-smelling stools. Severe colitis. Frequent flatulence, gas, and abdominal bloating. Dehydration. Sometimes severe abdominal cramps and tenderness in the stomach. Slight weight loss. Moderate anemia and effect of the bloody stools. Moderate fever. Mild fatigue and effect of dehydration. Unrelated symptoms. The amoeba may be then carried in the blood to the liver, resulting in the formation of an abscess that presents the following symptoms: fever, chills, mild diarrhea, pain in the upper right portion of the abdomen, jaundice, weight loss and hepatomegaly, lungs, cough and blood-stained sputum, amoebum swelling anywhere in the abdomen, especially ascending colon. Anal ulceration may occur by direct extension from the intestinal infection. Investigations. O, stool microscopy for cysts and mortal organisms. O, ultrasound scan. Treatment. O, correct any dehydration. O, treatment should start with a 10-day course of the antimicrobial drug metronidazole. Flageolate 108 hourly, chill 10/kg/body weight, or tinidazole torn daily for 5 days. O, amoebicidal luminal drug e.g. dioxanide furor, paramomycin, or iodoquinol to finish. Nursing and midwifery tropical medicine. Promote use of clean drinking water. Typhoid fever, enteric fever. Definition. Typhoid fever is an acute bacterial infection characterized by fever and spread through contaminated food and water. Causes. Typhoid fever is caused by Salmonella typhi and Salmonella partifia and B. Transmission. Typhoid fever is contracted by the ingestion of the bacteria in contaminated food or water. Patients with acute illness can contaminate the surrounding water supply through stool, which contains a high concentration of the bacteria. About 3–5% of patients become carriers of the bacteria after the acute illness. Some patients suffer a very mild illness that goes unrecognized. These patients can become long-term carriers of the bacteria. The bacteria multiply in the gallbladder, bile ducts, or liver and pass into the bowel. The bacteria can survive for weeks in water or dried sewage. The chronic carriers may have no symptoms and can be the source of new outbreaks of typhoid fever for many years. Signs and symptoms. Nursing and midwifery tropical medicine. O, abdominal pain is also possible. O, there is leukopenia with eosinopenia and relative lymphocytosis, but the classic Whittle test is negative in the first week. Second week. O, in the second week of the infection, the patient is very sick with high fever around 40 degrees C, 104 degrees F in bradycardia. O, delirium is frequent, calm, but sometimes agitated. O, rose spots appear on the low chest and abdomen in around a third of patients. O, the abdomen is distended and painful in the right lower quadrant. O, diarrhea can occur in this stage. The stool appears green with a characteristic smell, comparable to pea soup. However, constipation is also frequent. O, the spleen and liver are enlarged, hepatosplenomegaly and tender. O, the Whittle reaction is strongly positive with anti-O and anti-H antibodies. Blood cultures are sometimes still positive at this stage. Third week. In the third week of typhoid fever, a number of complications can occur. The dead fragments of the intestinal tissue may erode blood vessels, causing hemorrhage, or may perforate the intestinal wall, allowing the intestine's contents to enter the peritoneal cavity, peritonitis. Encephalitis. Metastatic abscesses, cholecystitis, endocarditis and osteitis. Dehydration may set in and the patient is delirious typhoid state. By the end of the third week, the patient is emaciated, fever starts reducing. Abdominal symptoms are marked and mental disturbance is prominent. Fourth week. Nursing and midwifery tropical medicine. Investigations. O stool for culture. O blood for culture. O Whittle test. Complications. Perforation. Hemorrhage. Peritonitis. Cholecystitis. Pneumonia. Heart failure. Osteomyelitis. Encephalitis. Meningitis. Mental confusion. Management. Hospital admission is usually recommended if there are severe symptoms, such as persistent vomiting, severe diarrhea, or a swollen abdomen. In hospital, the patient will be given antibiotic injections e.g. ciprofloxacin cipro, ceftriaxone, ampicillin, chloramphenicol, trimethoprim sulfamethoxazoline. Rehydrate the patient with ORS or intravenous fluids. Nursing and midwifery tropical medicine. Often, removal of the gallbladder at the site of chronic infection will cure the carrier. State. Surgery may be required if one develops any life-threatening complications, such as internal bleeding or intestinal perforation. Most people respond well to hospital treatment and improve within 3 to 5 days. However, it may be several weeks until you are well enough to leave hospital. General nursing care, i.e., vital observations, general hygiene, etc. Prevention. O keep the premises and kitchen utensils clean. Dispose rubbish properly. O keep hands clean and fingernails trimmed. O wash hands properly with soap and water before eating or handling food and after. Toilet or changing diapers. O drinking water should be from the microorganisms and should preferably be boiled. O avoid high-risk food like raw food or semi-cooked food. O wear clean, washable aprons and caps during food preparation. O clean and wash food thoroughly. Scrub and rinse fruits in clean water. O store perishable food in refrigerator, well covered. O cook food thoroughly. O consume food as soon as it is done. Nursing and midwifery tropical medicine. Malaria. Definition. Malaria is an acute febrile infectious disease caused by a parasite of the genus Plasmodium and is normally transmitted from person to person by female mosquitoes of the genus Anopheles. Malaria is characterized by cycles of chills, fever, pain, and sweating. Historical records suggest malaria has infected humans since the beginning of mankind. There are 4 species of malaria parasites which affect humans, namely O. Plasmodium falciparum, O. Plasmodium vivax, O. Plasmodium malariae, O. Plasmodium ovale, O. Plasmodium knowlesiae. Of these, Plasmodium falciparum is the most virulent malaria parasite in the world and also the most common malaria parasite in Uganda. Signs and symptoms. Fever is the most characteristic symptom of malaria. The fever in malaria is intermittent, i.e., it comes and goes many times. 3 phases can be distinguished in a typical attack of malaria. The cold stage, it is when the patient feels cold and shivers. The hot stage, it is when the patient feels hot. The sweating stage, it is associated with sweating and relief of symptoms. Loss of appetite, weakness and lethargy. Nursing and midwifery tropical medicine. Dehydration, splenomegaly. The following symptoms can occur in complicated and severe malaria. Change of behavior, confusion or drowsiness, altered level of consciousness or coma, convulsions, hypoglycemia, acidosis, difficulty in breathing due pulmonary edema or respiratory distress syndrome, acute renal failure, severe anemia, cough, hemoglobinuria, oliguria with very dark urine Coca-Cola or coffee color, jaundice, bleeding tendency, prostration, hyperparasitemia, hyperpyrexia, severe vomiting, transmission of malaria. Nursing and midwifery tropical medicine. An illustration of the life cycles of malaria parasites. The life cycle of a malaria parasite. 1. Malaria infection begins when an infected female Anopheles mosquito bites a person, injecting Plasmodium parasites in the form of sporozoites into the bloodstream. 2. The sporozoites pass quickly into the human liver. 3. The sporozoites multiply asexually in the liver cells over the next 7 to 10 days, causing no symptoms. 4. In an animal model, the parasites, in the form of merozoites, are released from the liver cells in vesicles, journey through the heart, and arrive in the lungs, where they settle within lung capillaries. The vesicles eventually disintegrate, freeing the merozoites to enter the blood. Nursing and midwifery tropical medicine. 8. The fertilized female gametes develop into actively moving eukaryotes that burrow through the mosquito's midgut wall and form oocysts on the exterior surface. 9. Inside the oocyst, thousands of active sporozoites develop. The oocyst eventually bursts, releasing sporozoites into the body cavity that travel to the mosquito's salivary glands. 10. The cycle of human infection begins again when the mosquito bites another person. Incubation period. The period between the mosquito bite and the onset of the malarial illness is usually 1 to 3 weeks, 7 to 21 days. Certain types of malaria P. vivax and P. ovale parasites can take much longer, as long as 8 to 10 months, to cause symptoms. These parasites remain dormant, inactive, or hibernating in the liver cells during this time. Unfortunately, some of these dormant parasites can remain even after a patient recovers from malaria, so the patient can get sick again. This situation is termed relapsing malaria. Diagnosis: black small square. Clinical signs and symptoms: black small square. Unfortunately, many diseases can mimic symptoms of malaria, for example, yellow fever, typhoid fever, respiratory tract infections, meningitis, otitis media, tonsillitis, skin sepsis, and even measles. Black small square. The classic and most used diagnostic test for malaria is the blood smear on a microscope slide that is stained to show the parasites inside red blood cells. Treatment: 1. Treatment of uncomplicated malaria. The recommended first-line medicine is artemether/lumefantrine cordim. First-line alternative treatment is aconate plus amidoquine, the alternative drug that may be used when artemether/lumefantrine is not available. Nursing and midwifery tropical medicine. Parenteral quinine or artemether are the alternatives to be used when artesunate is not available. Establish an IV line. Give fluids to correct dehydration according to body weight. 3. Treatment of malaria in pregnancy. Uncomplicated malaria. Plus first trimester, quinine tablets. Plus second and third trimesters, artemether/lumefantrine or quinine tablets. Severe malaria in pregnancy is treated with intravenous artesunate. 4. Antipyretic to reduce body temperature. Paracetamol 10/kg body weight every 6 hours in children. Adult 1 6 minutes 8:30. Tepid sponging or fanning. 5. Anticonvulsants e.g. diazepam 0.2 kg body weight IB or IM in adults. 6. Treat detectable cause of convulsions e.g. hypoglycemia with dextrose. 7. Nursing care. Give supportive care and symptomatic treatment such as tepid sponging for fever. Observations of TPR and BP. Take temperature for early and record all observations. Give health education regarding personal protection, prevention of malaria, and compliance with treatment. If there is vomiting, patient should take an antiemetic medicine a half to 1 hour before taking the antimalarial drugs. The patient should rest for 1 minute to 2 hours after taking the medicine due to the risk of dizziness, vomiting, and hypotension. The patient should be given psychological support by encouraging the patient and giving comfort. Encourage a nourishing diet with plenty of oral fluids. If a patient is unable to eat or drink, pass a nasogastric tube. Monitor fluid intake and output. Institute a fluid balance chart. Nursing and midwifery tropical medicine. Shock. Spontaneous bleeding. Acidosis. Hemoglobinuria, hemoglobin in urine. Jaundice. Repeated generalized convulsions. Prevention and control. Give effective treatment and prophylaxis. Eliminate the parasites from the human population by early diagnosis and effective treatment. Protect vulnerable groups with chemoprophylaxis. The following drugs are used: chloroquine, doxycycline, mefloquine, primaquine. Give IPT to all pregnant women. Reduce human mosquito contact. Use insect-treated nets. Destroy adult mosquitoes by spraying of dwellings with insecticides or use of knock-down sprays. Wear clothes which cover the arms and legs and use repellent mosquito coils and creams on the skin when sitting outdoors at night. Control breeding sites. Nursing and midwifery tropical medicine. Measles. Definition: measles, also known as morbilli, is an acute, highly communicable infection of the respiratory system caused by a virus of the genus morbillivirus, characterized by an generalized skin rash, fever, and inflammation of the mucous membrane. Measles is spread through respiration contact with fluids from an infected person's nose and mouth and is highly contagious. Incubation period is 9 to 12 days. Risk factors for measles: children with immunodeficiency. Travel to areas where measles is endemic or contact with travelers from endemic areas. Malnutrition. Pregnancy. Vitamin deficiency. Signs and symptoms: catarrhal stage. High degree fever. The fever may reach up to 40 C. The 3 CS cough, or is a common cold, conjunctivitis, red eyes. Anorexia. A skin rash characteristic measles rash is classically described as generalized maculopapular erythematous rash that begins several days after fever starts. It starts on the back of the ears, spreads to the neck and head before spreading to Cover most of the body. Complex spots seen inside the mouth diagnostic for measles. Desquamation stage. Diarrhea is common. Skin lesions peel off. Rash fades. Temperature falls. Nursing and midwifery tropical medicine. Diagnosis. Clinical presentation and history of contact with measles. Measles IgM antibodies. Complications. Diarrhea. Pneumonia. Itis media. Acute encephalitis. Corneal ulceration leading to corneal scarring. Protein energy malnutrition PEM. Larin. Cotracheal bronchitis LTB. Bronchitosis because of long-term blockage of small bronchi. Treatment. There is no specific treatment for measles. Most patients with uncomplicated measles will recover with rest and supportive treatment. In complicated cases, admit the patient to hospital. Give a balanced diet with protein and energy foods. Increase fluid intake. Antibiotics are required for bacterial pneumonia, sinusitis, and bronchitis that follow measles. All other treatment address symptom, i.e. ibuprofen or paracetamol to reduce fever and pain. Vitamin supplement 200,000 IU. First dose at diagnosis, second dose the next day, third dose 2-4 weeks later. Apply tetracycline eye ointment 1% 12 hourly for 5 days. If there is stomatitis, clean the mouth 4 minutes 6 hourly. If there is diarrhea, give ORS, plenty of fluids. If there is convulsions, phenobarbital can be given. Treat otitis media with amoxicillin and earwicking. Nursing and midwifery tropical medicine. Avoid contact between infected persons and the uninfected. Tuberculosis. Introduction. Tuberculosis, or TB short for tubercle bacillus, is a common and in many cases fatal infectious disease caused by various strains of mycobacteria. Tuberculosis typically attacks the lungs, but can also affect other parts of the body. It affects 1/3 of the world's population, 1/310. In HIV/AIDS, the probability of getting tuberculosis is high. Etiology. It is caused by Mycobacterium tuberculosis, a small aerobic, non-motile bacillus. Mode of spread. It is spread through the air when people who have an active TB infection cough, sneeze, or otherwise transmit respiratory fluids through the air. Through blood, hematogenous spread. Types. Pulmonary tuberculosis. Extrapulmonary tuberculosis. Risk factors. A number of factors make people more susceptible to TB infections. The most important risk factor globally is HIV. 13% of all people with TB are infected by the virus. Tuberculosis is closely linked to both overcrowding and malnutrition, making it one of the principal diseases of poverty. Inhabitants and employees of areas where vulnerable people gather, e.g. prisons and homeless shelters. Medically underprivileged and resource-poor communities, high-risk ethnic minorities. Children in close contact with high-risk category patients. Healthcare providers serving TB patients. Chronic lung disease is another significant risk factor. Those who smoke cigarettes have nearly twice the risk of TB than non-smokers. Other disease states can also increase the risk of developing tuberculosis. These include alcoholism and diabetes mellitus, epidemiology, black small square. 1/3 of the world population is infected with tuberculosis. Black small square. It causes 25% of adult preventable deaths, and 3/4 of these people are in productive age. Black small square. Nursing and midwifery tropical medicine. Black small square. Africa has the highest incidence rate. The incidence rate is the number of new cases per population at risk in a given time period, i.e. the effective rate in the world, with annual incidence rate of 345/100,000 people. Black small square. The infection is higher in men than in women. Primary tuberculosis. It occurs in persons who have never had previous exposure to tubercle bacilli. Tubercle bacilli are inhaled, reach the lungs, and lodge in alveoli where they multiply. They then spread to hilar lymph nodes, from where they can spread to the whole body via lymphatic system and blood. 6 weeks after primary infection, a body develops an immune response to the tubercle bacilli, and this stops the multiplication of the tubercle bacilli. Some bacilli die, and the remaining walled off by epithelioid cells, immune cells, forming a gonfocus. This can stay for years in primary tuberculosis. The gonfocus and hilar lymphadenopathy form a primary complex in primary tuberculosis. 10% of the people who get primary infection develop tuberculosis disease. Secondary tuberculosis. It is due to reactivation of tubercle bacilli acquired in primary infections. Reinfection by tubercle bacilli in a person who was already exposed to the organisms. Pathogenesis. OTB infection begins when the mycobacteria reach the pulmonary alveoli where they invade and replicate. O tuberculosis of the lungs may also occur via infection from the bloodstream. This hematogenous transmission can also spread infection to more distant sites, such as peripheral lymph nodes, the kidneys, the brain, and the bones. O infection with Mycobacterium tuberculosis causes an inflammatory response leading to granuloma formation, collection of activated macrophages, T lymphocytes, B lymphocytes, and fibroblasts are among the cells that aggregate to form granulomas, with lymphocytes surrounding the infected macrophages. Other lymphocytes form a peripheral rim around the tubercle bacilli, forming a gun focus. O bacteria inside the granuloma can become dormant, resulting in latent infection. Another feature of the granulomas is the development of abnormal cell death, necrosis in the center of tubercles caseation. If TB bacteria gain entry to the bloodstream from an area of damaged tissue, they can spread throughout the body and set up many foci of infection, all appearing as tiny, white tubercles in the tissues. This severe form of TB disease, most common in young children and those with HIV, is called miliary tuberculosis. All tissue destruction and necrosis are often balanced by healing and fibrosis. Affected tissue is replaced by scarring and cavities filled with caseous necrotic material. Clinical features: pulmonary TB, black small square, fever and chills, black small square, night sweats. Nursing and midwifery tropical medicine, black small square, weight loss, black small square, easy fatigability, black small square, cough for more than 3 weeks with or without hemoptysis, black small square. Significant finger clubbing may also occur. Black small square, chest pain, black small square, productive cough or non-productive and smear-negative TB, black small square, lymphadenopathy, extrapulmonary. In 15–20% of active cases, the infection spreads outside the lungs, causing other kinds of TB. These are collectively denoted as extrapulmonary tuberculosis. Extrapulmonary TB occurs more commonly in immune-suppressed persons and young children. In those with HIV, this occurs in more than 50% of cases. Notable extrapulmonary infection sites include the pleura and tuberculous pleurisy, the central nervous system and tuberculous meningitis, the lymphatic system, TB lymph nodes, the genitourinary system and urogenital tuberculosis, the bones and joints and pus disease of the spine. When it spreads to the bones, it is also known as osseous tuberculosis, a form of osteomyelitis. Sometimes, bursting of a tubercular abscess through skin results in tuberculous ulcer. An ulcer originating from nearby infected lymph node is painless. The potentially more serious, widespread form of TB is called disseminated TB, commonly known as miliary tuberculosis. Miliary TB makes up about 10% of extrapulmonary cases. Diagnosis: investigations. Signs of lung disease or constitutional symptoms lasting longer than 2 weeks. Chest X-ray. Multiple sputum cultures for alcohol acid fast bacilli spot sample and early morning sample. Tubercle and skin tests, Matthew or Heath test. Is a preferred test for testing for TB in children and also determining people at risk of developing TB. Hematological tests. Full blood cell count of BCE. Erythrocyte sedimentation rate, ESR. Increased ESR strongly creates suspicion of the disease. Tissue biopsy. Relationship between HIV and TB. Effects of HIV on TB. Development of active TB once infected with HIV. High risk of becoming reinfected with a second strain of TB. The incidence of TB increases, cases of TB on increase because of TB. Presentation of TB changes once one is infected with HIV. There are clinical changes, e.g. non-productive cough, no hemoptysis, bacteriological changes, e.g. instead of cavitations. There is a miliary pattern. Development of complications of TB quickens. TB treatment also changes once one is HIV positive. Rifampicin is replaced by rifampicin. Nursing and midwifery tropical medicine. Effects of TB on HIV. TB increases the replication of HIV, hence increasing the viral load and fastening the onset of AIDS. TB is one of the commonest opportunistic infections in HIV and is the commonest cause of death in 30 minutes, 40% in people living with HIV/AIDS. Anti-TB treatment, e.g. rifampicin, interferes with ARVs, especially nevirapine and protease inhibitors, hence management of TB changes. Consequences of dual infection with HIV and TB. Increased morbidity and mortality. Increased recurrence rate of TB after completion of treatment. Drug resistance leading to multi-drug resistance, NDR, and extra drug resistance, XDR, and DRTB. Added TB. increase in defaulter rates, hence compromising adherence, increase in side effects, toxicity of agents used, management of HIV and TB co-infection. Treat TB first. ARVs are not an emergency. Start ARVs if CD4 350. After finishing TBRX course or after completing initial intensive phase. After 2 weeks on TBRX. Consider drug interactions in HIV regimen selection. DOTs and careful monitoring. Monitor for toxicity and act quickly. Opportunistic infections prophylaxis as indicated. Complications of TB. Pleural effusion. Pericardial effusion. Empyema. Pneumothorax. Lung fibrosis. Lung collapse. Seeding of infection to other organs causing extrapulmonary TB, e.g. TB meningitis. Treatment of TB. Aims. To cure the patient. Prevention of complications and death from TB. Reduce TB transmission. Nursing and midwifery tropical medicine. Failure. It is a person who continues becoming smear positive at 5 months despite taking anti-TB Rx adequately or was smear negative and becomes smear positive at 2 months. Defaulter is a patient who starts taking anti-TB drugs for more than 4 weeks and interrupts treatment start, taking the drugs for 4 or more weeks. Drugs used. Black small square. Rifampicin R. Black small square. Isoniazid H or INH. Black small square. Ethambutol E. Black small square. Pyrazinamide Z. Black small square. Streptomycin S. Treatment regimen. Short course TB treatment regimen. Patient category type of TB. Initial phase. Continuation phase. 1. New smear positive. 2. New smear negative. 3. Severe extrapulmonary. 2A is 6A. 4. Previously treated smear. Plus V. Relapse. Failure to respond. Return after interruption. 2C/1A is 5 EHR. 5. Any form of TB in children. 6. Adult non-severe extra. Pulmonary. 2 HRZ. 4 HR. Non-anti-TB drugs used in TB. Pyridoxine Fit B6 for treatment of peripheral neuropathy, a side effect of isoniazid. Steroids in the treatment of OTB meningitis. OTB pericarditis. OTB of adrenals. Directly observed therapy short course. How it works. Black small square. The country has adopted community-based TB care with dots. Black small square. There is a trained worker or treatment supporter who watches the patient to swallow, takes the dose of treatment daily and records on the TB card. Black small square. Dots is a standard of care for all cases and suspects of TB. Black small square. Dots can lead to decrease in relapse, defaulter and acquired drug resistance. Black small square. Nursing and midwifery tropical medicine. Black small square. The sub-county health worker transfers the information to the sub-county health worker register and then goes to the village where the patient comes from and identifies a treatment supporter together with the patient. The treatment supporter is trained on observing patient take treatment, recording on the TB card, keeping the drugs, reminding the patient to come for follow-up assessment at the health unit at 2 months, 5 months and 8 months. Black small square. Sub-county health worker collects medication from the H/unit and brings it to the treatment supporter. Prevention. Early detection of cases and proper management. Early case findings. Health education about TB spread and prevention. Nursing and midwifery tropical medicine. Leprosy. Leprosy, also known as Hansen's disease, is a chronic infection caused by the bacteria Mycobacterium leprae and Mycobacterium lepromatosis. It primarily affects the skin and peripheral nerves. Cause. Leprosy is caused by Mycobacterium leprae and Mycobacterium lepromatosis. Lepromatosis is a relatively newly identified mycobacterium isolated from a fetal case of diffuse lepromatous leprosy in 2008. Transmission. Nasal route via secretions. Transplacental and breastfeeding. Genetic predisposition. Types. Lepromatous leprosy 90%. Tuberculoid leprosy. Borderline leprosy. Undeterminate dysmorphic leprosy. Incubation period. The incubation period of leprosy is 2-5 years but may increase to 8-12 years in lepromatous leprosy. Signs and symptoms. Black small square anesthetic skin lesions. Black small square thickened peripheral nerves. Black small square nasal stuffness. Black small square shadow nose. Black small square loss of eyebrows and lashes. Black small square erythema nodosum. Black small square inflammatory eye changes. Investigations. Histamine test. Nursing in midwifery tropical medicine. Differences between tuberculoid, lepromatous, and borderline leprosy. Cutaneous lesion. Tuberculoid. Lepromatous. Borderline. Characteristic number of lesions. Few. Many. Size of lesion. Large. Small. Both large and small. Symmetry of lesions. Asymmetrical. Symmetrical. Symmetrical. Surface of lesions. Rough and scaly. Smooth. Rough and scaly. Edges. Sharp. They. Sharp. Treatment. Tuberculoid leprosy. Dapsone plus rifampicin. Lepromatous. Dapsone plus rifampicin plus clofazimine. Borderline leprosy. Dapsone. Non-leprosy drugs used in the management of leprosy. Steroids. Vitamin B complex. Drugs for leprosy are in fixed drug combinations called MDT multi-drug therapy. Complications of leprosy. Omatorosis, loss of eyebrows and eyelashes. Nasal bridge collapse. Ocular complications, corneal ulcer, blindness. Leonine faces. Loss of sensation to heat, pain and light touch. Multiple ulcerations due to damage of nerves and loss of sensation. Nerve enlargement. Orchitis. Disuse of some parts. Nursing and midwifery tropical medicine. Tetanus. Definition. This is an acute infectious disease of the central nervous system caused by Clostridium. The tawny end is characterized by spasms of the skeletal muscles frequently attacking the muscles of the jaw. Tetanus is commonly known as lockjaw. Cause. Tetanus is caused by the exotic sins of Clostridium tetani. The organism can live for a long time in any condition, especially dirty environments. So it can be found in dust, soil, or grass. The Clostridia can be normal organisms in the alimentary canal of animals, but when passed out and gain entry to human body, they become harmful. The organism can be found in cows, horse, sheep, or goat. Incidence. In babies born at home before arrival to the hospital. In homes where domestic animals are kept. Pathophysiology. The bacilliospores usually gain access through a deep punctured, cut wounds inflicted on the body where they multiply in anaerobic conditions. All dirty wounds are dangerous. When organisms enter the wound, they release two forms of exotoxins into surrounding tissues, tetanospasmin and tetanolysin. Tetanospasmin is a potent toxin that affects the CNS to produce the clinical manifestations. The toxins poison the motor nerve cells of the spinal cord and the brain, with the result that spasms occur in the muscles supplied by corresponding nerves. Route of entry. Infected ulcerative wound. Postoperative wounds. Nursing and midwifery tropical medicine. Jiggers or foreign bodies. Burns and scalds. Signs and symptoms. Stiffness of the muscles, particularly those of the jaw. Spasms of the muscles of the face, cheek, and jaw lead to difficulty in opening the mouth, a condition called trismus. The angles of the mouth are pulled outwards, causing a false smile referred to as the sardonicus devil's grin. The head is thrown back and the back is arched with great rigidity of the muscles of the neck, a condition known as opisthonos. Signs of inflammation, e.g., swelling of the cord, wet cord, offensive smell or pus, discharge from the cord, raised temperature and rapid pulse, loss of weight due to starvation, retention of urine or stool due to spasms of the sphincters. Sphincter may rupture in severe cases. Spasms of the muscles of the mouth and esophagus render swallowing difficult. Spasms of respiratory muscles cause long periods of anoxia and death may occur. There may be a wound or history of a wound. Management. The aim of management is to control spasms, destroy the organism in spreading toxins, prevent complications, provide nutrition, specific treatment. Penicillin is administered in all cases of tetanus to destroy the organism. Anti-tetanus serum is given. Nursing and midwifery tropical medicine. The door should be fitted with suitable closing material /spring to prevent slamming. The nurse should warm her /hand before touching the patient to avoid stimulating the child. Sedation and muscle relaxation, e.g., chlorpromazine Largactil alternating with diazepam 6 hourly by nasogastric tube. Example of 6-hourly regimen. 6 minus 9. 9 minus 12 upam. 12 minus 3 pam. 3 minus 6 pam. 6 minus 9 upam. 9 minus 12. 12 minus 3 m. 3 minus 6 m. 6 minus ninim. Largactil. Diazepam. General management. Maintain close observations and attention to a clear airway. Monitor temp. 2 or 4 Hli. Pulse and respirations may be done 4 Hli depending on severity and condition of the patient. Monitor spasms, noting strength, frequency, duration, and part involved. Use a spasm chart to record your findings. A mucus extractor may be required for clearing the airway. Diet, maintain adequate nutrition. A nasogastric tube is passed for feeds and drugs. Drugs are administered this way to avoid stimulating the spasms with injections. Prevent aspiration of fluids into the airway. Catheterize the patient. Maintain a fluid balance chart. Initially IV fluids may be required and later by NGT. Hygiene, clean the cord daily with normal saline. Do oral care carefully. Turn the patient too early to prevent pressure sores. Prevent future tetanus from occurring by ensuring a full course of DPT. Use sterile equipment to prevent cross-infection. Care of the bowel and the bladder. Patient should be able to pass stool and urine. Give drugs as prescribed. Physiotherapy for deep breathing exercises and active limb movements. Prevention. Nursing and midwifery tropical medicine. Ensure safe and clean practices during childbirth. Certain practices must be discouraged, e.g. application of cow dung on the cord of a child. Health education on cleaning wound thoroughly well with plenty of water and soap to prevent infection. Cover all wounds well with sterile dressing. Seek medical attention early for all cut wounds. Wear gumboots when digging. Complications. Fracture of bones or the spine due to spasms. Pneumonia due to heavy sedation. Brain damage. Growth retardation. Exhaustion. Respiratory failure. Nursing and midwifery tropical medicine. Zoonosis. Infectious animal diseases that can be transmitted to humans. Rabies. It is a disease of animals incidentally transmitted to human beings by a bite of a rabid animal. Rabies is caused by rabies virus. It is transmitted by a bite of a rabid animal, e.g. dog, donkey, horse, jackal, fox, mongoose, hyena, cat, cattle. Epidemiology. It is common in tropical Africa, especially in Tanzania. The disease is highly fatal. Case fatality rate is 99.9-100%. The rabies virus prefers salivary gland and nervous tissue and causes encephalitis and death. Man becomes infected when he is bitten by a rabid animal, usually a dog. The saliva left behind in a wound contains the virus, which then enters the CNSY nerves and reaches the brain. Clinical features. Incubation period is 2 weeks to 1 year, averagely 3 months depending on site of bite, i.e. whether far or near the brain, type of wound abrasion, small wound, deep wound, etc. Dose of virus deposited in the wound. Tooth marks or scratches. Bleeding and tissue necrosis. Convulsions. Anxiety. Depression. Paralysis of limbs. Spasms of pharyngeal muscles. Nursing and midwifery tropical medicine. Photophobia. Signs of meningism stiffness, positive cunning, sinus meningeal irritation, in which the patient is unable to extend his legs at the knee when the thighs are held at a right angle to the body. Note, survival for more than 1 week is unlikely when symptoms appear. Animal. Abnormal behavior. Biting on slightest provocation. Depressed animal or curled in a corner. Death occurs in 10 days. Management. No cure is available and management is symptomatic. Isolation of the case. Ensure barrier nursing. Oxygen resuscitation. Intravenous therapy. Nasogastric tube for feeding and drugs. First aid treatment. Wash out the wound with plenty of water, soap and brush. Rinse with plenty of water. Apply an antiseptic. Do surgical toilet. Do not suture. Apply dressing to prevent or stop bleeding. Give tetanus toxoid vaccination. Take a very good history and refer to hospital for anti-rabies. As part of local treatment in all cases of possible exposure, carefully infiltrate rabies immunoglobulin RIG in and around the wound. Handling animal bites. If the animal is available and looks healthy, reassure the patient but let him go home. And come back after 10 days after doing all first aid measures. Closely observe the animal for signs of rabies for 10 days. If the animal shows signs. Nursing and midwifery tropical medicine. If animal dies, cut off its head and take to DHO and veterinary officer for investigations. Bury the remaining parts. Anti-rabies vaccination 1, 3, 7, 14, 28 or day 1, 3, 7, 14, 21, 30. Anthrax. It is an acute bacterial disease primarily of animals but occasionally affects man. Occurrence and medical importance. Black small square is a disease of cattle, goats, and sheep. Black small square occurs in epidemics. Black small square may spread from one area to another, especially when animals are moved from one area to another. Black small square may present in different ways depending on the part of entry in the body, e.g. anthrax of the skin, common in person tanned on cattle, hides and skins, the butchers. Anthrax of the lungs, common in people working with infected wool. Anthrax of bowel, common in people who eat meat of sick or dead animals. Causes. Anthrax is caused by a spore-forming bacillus called Bacillus anthracis. The spores are formed when the bacillus are exposed to air. Spores are extremely resistant to climatic conditions and can survive for many years in soil. Clinical picture. Low point of entry skin. Papules. Blisters. Ostules. Black central necrosis of pustules. Extensive edema. Painless swelling. Nursing and midwifery tropical medicine. Mild symptoms of early flu-like symptoms. Serious respiratory distress pneumonia. Talk. Case fatality is high. Low point of entry digestive tract. Vomiting. Diarrhea. Fever. Sepsis/septicemia. Abdominal pain. Case fatality is moderate. Investigations. Skin aspiration of fluid of vesicles for culture. Respiratory tract sputum culture. Digestive tract stool culture. Treatment. Aims. To prevent spread of infection. To treat or prevent shock. To treat the cause. Nursing and midwifery tropical medicine. Brucellosis. Brucellosis, also called malt fever or undulant fever, is a highly contagious bacterial infection caused by ingestion of unpasteurized milk or undercooked meat from infected animals or close contact with their secretions. It is common among people who work with infected livestock or animal products. These include occupational exposure of laboratory workers, abattoirs, veterinarians, slaughterhouse workers, farmers, machomo roasters. Cause. Brucellosis is caused by Brucella species. These include O. Brucella abortus cattle, O. Brucella canis dog, O. Brucella melitensis goat and sheep, O. Brucella wise pig. Signs and symptoms. The symptoms are like those associated with many other febrile diseases. The duration of nursing and midwifery tropical medicine. Myalgia muscle pain. Leukopenia and anemia. Orchitis inflammation of the testes. Melitoxemia presence of brucellosis in blood. Transmission. The disease is transmitted by close contact with infected animals, their tissues, meat, blood, urine, vaginal discharge, aborted fetuses. The disease is also transmitted by ingestion of milk and milk products from infected animals. Diagnosis. 1. Blood cultures. 2. Bone marrow cultures. 3. Brucella antibody test BAT. 4. Hepatic biopsy granulomatous hepatitis. 5. X-ray of vertebrae erosion of the anterior superior corner of lumbar vertebrae and marked osteophytosis or suspicious of brucellic spondylitis. Treatment and prevention. Antibiotics such as tetracyclines, rifampicin, and the aminoglycoside streptomycin and gentamicin are effective against Brucella bacteria. The use of more than one antibiotic is needed for several weeks because the nursing and midwifery tropical medicine. Triple therapy of doxycycline with rifampin and cotrimoxazole has been used successfully to treat neurobrucellosis. Prevention. Boil milk before use. Pasteurizing all milk that is to be ingested by human beings. Early diagnosis and treatment of infected persons. Stop or restrict transportation and eating beef/animal products in infected areas. Complications. Black small square or hydis. Black small square osteomyelitis of vertebrae. Nursing and midwifery tropical medicine. Schistosomiasis. Schistosomiasis, also known as bilharzia or snail fever, is a disease of the large intestine and urinary tract caused by parasitic worms of the schistosoma blood fluke. It may infect the urinary tract or intestines. Cause. Schistosoma hematobium causes urinary schistosomiasis. Schistosoma mansoni and Schistosoma intercalatum cause intestinal schistosomiasis. Schistosoma japonicum and Schistosoma macundi cause Asian intestinal schistosomiasis. Avian schistosomiasis species cause somersetch. Transmission. The disease is spread by contact with water that contains the parasites. These parasites are released from freshwater snails that have been infected. The larvae form Sarcariosschistosoma penetrates the skin from contaminated water. Epidemiology. Schistosomiasis affects almost 210 million people worldwide. An estimated 12,000 to 200,000 people die from it a year. The disease is most commonly found in Africa, Asia, and South America. Around 700 million people in more than 70 countries live in areas where the disease is common. Schistosomiasis is second only to malaria as a parasitic disease with the greatest signs and symptoms. Above all, schistosomiasis is a chronic disease. Schistosoma hematobium, urinary tract. Painless blood-stained urine at the end of urination, hematuria. Frequency of urination, cystitis and fibrosis. Hydronephrosis, pyonephrosis, hypertension, uremia. Fatigue. Genital sores. Schistosoma mansoni GIT. Abdominal pain. Frequent stool with blood-stained mucus. Palpable liver hepatomegaly. Nursing and midwifery tropical medicine. Cough. Diarrhea. Fever. Fatigue. Other symptoms. Skin symptoms at the start of infection, mild itching, and a papular dermatitis of the feet. In other parts after swimming in polluted streams containing cercariae. Life cycle. Snails. The life cycles of all human schistosomes are similar. Parasite eggs are released into the environment from infected individuals hatching on contact with fresh water to release the free-swimming Miracidium. Miracidia infect freshwater snails by penetrating the snail's foot. After infection close to the site of penetration, the Miracidium transforms into primary mother sporocyst. Germ cells within the primary sporocyst will then begin dividing to produce secondary daughter sporocysts, which migrate to the snail's hepatopancreas. Once at the hepatopancreas, germ cells within the secondary sporocyst begin to divide. Again, this time producing thousands of new parasites, known as cercariae, which are the larvae capable of infecting mammals. Humans. Penetration of the human skin occurs after the cercariae have attached to and explored the skin. The parasites secrete enzymes that break down the skin's protein to enable penetration of the cercarial head through the skin. As the cercaria penetrates the skin, it transforms into a migrating schistosomulum stage. The newly transformed schistosomulum may remain in the skin for 2 days. From here, the schistosomulum travels to the lungs, where it undergoes further developmental changes necessary for subsequent migration to the liver. 8 to 10 days after penetration of the skin, the parasite migrates to the liver sinusoids. S. mansoni and S. japonicum worms develop an oral sucker after arriving at the liver, and it is during this period that the parasite begins to feed on red blood cells. The nearly mature worms pair and relocate to the mesenteric or rectal veins. S. hematobium schistosomia ultimately migrate from the liver to the bladder, ureters, and kidneys through the hemorrhoidal plexus. Parasites reach maturity in 6 to 8 weeks, at which time they begin to produce eggs. Many of the eggs pass through the walls of the blood vessels and through the intestinal wall to be passed out of the body in feces. Schistosoma hematobium eggs pass through the ureteral or bladder wall and into the urine. Only mature eggs are capable of crossing into the digestive tract, possibly through the release of proteolytic enzymes, but also as a function of host immune response, which fosters local tissue ulceration. Worm pairs can live in the body for an average of 4.5 years, but may persist up to 20 years. Diagnosis. Nursing and midwifery tropical medicine. History of staying in an endemic area. Urine examination for schistosoma hematobium ova. Stool examination for schistosoma mansoni ova. Bladder X-ray for calcification. Ultrasound for urinary tract. Cystoscopy. Detection of parasitic antigens by ELISA blood sample. Tissue biopsy, rectal biopsy SNP for all species and biopsy of the bladder for S. hematobium may demonstrate X when stool or urine examinations are negative. Treatment. Schistosomiasis is readily treated using a single oral dose of the drug praziquantel, annually 14/kg. Prevention. Black small square. Avoid defecating or urinating in or near water. Black small square. Avoid washing or stepping in contaminated water. Black small square. Effective treatment of cases. Nursing and midwifery tropical medicine. Dracunculiosis. Dracunculiosis, also called guinea worm disease, is an infection by the guinea worm affecting the subcutaneous and deeper tissues. A person becomes infected when he/she drinks water that contains water fleas infected with guinea worm larvae. Cause. Dracunculus medinensis, transmitted to man by drinking water containing water flea or small crustacean infected with larvae of the guinea worm. Incubation period. About 2-3 weeks, i.e. from the vesicle rupturing until when larvae has been completely evacuated from the uterus of the gravid worm. Signs and symptoms. Adult worm may be felt beneath the skin. Local redness, tenderness, and blister usually on the foot at the point where the worms comes out of the skin to discharge larvae into the water. There may be fever, nausea, vomiting, diarrhea, and dyspnea. Generalized urticaria and eosinophilia before vesicle formation. There may be difficulty in walking or work. Diagnosis. Dracunculosis is diagnosed by seeing the worms emerging from the lesions on the legs of infected individuals. Microscopic examinations of the larvae. Life cycle of Dracunculus medinensis. Guinea worm disease is caused by drinking water contaminated by water fleas. Microscopic arthropods known as coprid cyclopoids that host the Dracunculus medinensis larvae. After ingestion, the copepods die and are digested, thus releasing the larvae, which then penetrate the host stomach or intestinal wall and then enter into the abdominal cavity and retroperitoneal space. After maturation, which takes approximately 3 months, mating takes place. The male worm dies after mating and is absorbed. Approximately 1 year after mating, the fertilized females migrate in the subcutaneous tissues. Nursing and midwifery tropical medicine. Within 72 hours, the blister ruptures, exposing one end of the emergent worm. The blister causes a very painful burning sensation as the worm emerges, and the sufferer will often immerse the affected limb in water to relieve the burning sensation. When a blister or open sore is submerged in water, the adult female releases hundreds of thousands of guinea worm larvae, thereby contaminating the water. Infected copepods can live in the water for up to 4 months. Diagnosis. Dracunculosis is diagnosed by seeing the worms emerging from the lesions on the legs of infected individuals. Microscopic examinations of the larvae. Active larvae can be obtained by immersing protruding female in a container with water. Radiological test reveals dead calcified worms. Treatment. The first step is to do a controlled submersion of the affected area in a bucket of water. This causes the worm to discharge many of its larvae, making it less infectious. Submersion results in relief of the burning sensation and makes subsequent extraction of the worm easier. Slow extraction of the worm. Avoid breaking the worm. Clean and dress the ulcer to prevent secondary bacterial infections such as tetanus. Give tetanus vaccination. Analgesics can be used to help reduce swelling and pain. Antibiotic ointments can help prevent secondary infections at the wound site. Use of metronidazole or thiabendazole may make extraction easier, but also may lead to migration to other parts of the body. Prevention. 1. Prevent people from drinking contaminated water containing the cyclid copepod water flea. Drink water drawn only from sources free from contamination, such as a borehole or wells. Filter all drinking water, using a fine mesh cloth filter like nylon or sand filters to remove the guinea worm-containing crustaceans. Boil the water. Treat water sources with larvicides to kill the water fleas. 2. Prevent people with emerging guinea worms from entering water sources used for drinking. Community-level case detection and containment is key. For this, staff must go door to door, looking for cases, and the population must be willing to help and not hide their cases. Immerse emerging worms in buckets of water to reduce the number of larvae in those worms, and then discard that water on dry ground. Discourage all members of the community from setting foot in the drinking water source. Complications. Arthritis. Nursing and midwifery tropical medicine. Tetanus infection. Abscess formation. Cellulitis if worm breaks. Onchocerciasis. Onchocerciasis, also known as river blindness, is a disease caused by infection with the parasitic worm Onchocerca volvulus. It is the second most common cause of blindness due to infection after trachoma. Transmission. The parasite worm is spread by the bites of a black fly simulium fly. These flies live near rivers, therefore the name of the disease. Signs and symptoms. Skin. Intense itching. Swelling. Acute papular onchodermatitis scatter pruritic papules. Depigmentation of its skin appearance, usually on anterior lower leg. Scaly, wrinkled skin, lizard skin. Hanging groin. Skin nodules. Lymphadenopathy. Ocular involvement. Provides the common name associated with onchocerciasis, river blindness. Sclerosing keratitis. Iridocyclitis. Corneal opacities. Blindness in extreme cases. Others. Onchocerciasis has been associated with an unusual form of epilepsy and nodding disease. Syndrome. Growth retardation. Nursing and midwifery tropical medicine. 3. The larvae matured into the second larval stage and moved to the proboscis and into the saliva in its third larval stage. Maturation takes about 7 days. 4. The black fly takes another blood meal, passing the larvae into the next human host blood. 5. The larvae migrate to the subcutaneous tissue and undergo 2 more molts. They form Nodules as they mature into adult worms over 6 to 12 months. 6. After maturing, adult male worms mate with female worms in the subcutaneous tissue to produce between 700 and 1500 microfilaria per day. 7. The microfilaria migrate to the skin during the day, and the black flies only feed in the day, so the parasite is in a position for the female fly to ingest it. Black flies take blood meals to ingest these microfilaria to restart the cycle. Diagnosis: from history and examination, skin snip biopsy, blood from microfilaria, microscopy. Immune diagnosis: it looks at hypersensitivities. Excision of nodules for adult worms. Treatment: ivermectin mectizin. Infected people can be treated with 2 doses of ivermectin, 150 mg/kg, 6 months apart, repeated every 3 years. Antibiotics: doxycycline is used to kill the Wolbachia bacteria that live in adult worms. Prevention and control: ivermectin treatment of affected people. Nursing and midwifery tropical medicine. Trypanosomiasis. Trypanosomiasis, or sleeping sickness, is a parasitic disease transmitted to humans by tsetse flies, belonging to the genus Scleosma. Cause: it is caused by protozoa of the species Trypanosoma brucei. There are 2 types that infect humans: Trypanosoma bruceigambiens, Trypanosoma brucei rhodesians. Trypanosoma brucei affects only animals. Transmission: both are usually transmitted by the bite of an infected tsetse fly and are most common in rural areas. Signs and symptoms: African trypanosomiasis symptoms occur in 2 stages. Hemolymphatic phase: black small square. Fever: black small square. Headaches: black small square. Joint pain: black small square. Itching: black small square. Swelling of lymph nodes: black small square. Occasionally, a red so-called chancre will develop at the location of the tsetse fly bite. Neurological encephalitic phase: it begins when the parasite invades the central nervous system by passing through the blood-brain barrier. Black small square. Disruption of the sleep cycle: sleeping sickness: black small square. Confusion: black small square. Tremor: black small square. General muscle weakness: black small square. Hemiparesis and black small square. Paralysis of a limb: black small square. Irritability: black small square. Psychotic reactions: black small square. Aggressive behavior: black small square. Apathy, which can sometimes dominate the clinical diagnosis. Nursing and midwifery tropical medicine. Life cycle: the tsetse fly genus Glossina is a large, brown, biting fly that serves as both a host and vector for the trypanosome parasites. While taking blood from a mammalian host, an infected tsetse fly injects metacyclic trypamastigotes into skin tissue. From the bite, parasites first enter the lymphatic system and then pass into the bloodstream. Inside the mammalian host, they transform into bloodstream trypamastigotes and are carried to other sites throughout the body, reach other body fluids e.g. lymph spinal fluid, and continue to replicate by binary fission. A tsetse fly becomes infected with bloodstream trypamastigotes when taking a blood meal on an infected mammalian host. In the fly's midgut, the parasites transform into pericyclic trypamastigotes, multiply by binary fission, leave the midgut, and transform into epimastigotes. The epimastigotes reach the fly's salivary glands and continue multiplication by binary fission. The entire life cycle of the fly takes about 3 weeks. In addition to the bite of the tsetse fly, the disease can be transmitted by mother-to-child infection. The trypanosome can sometimes cross the placenta and infect the fetus. Laboratories: accidental infections, for example, through the handling of blood of an infected person, and organ transplantation, although this isn't common. Blood transfusion. Sexual contact. Host flies, Tabanidae, and stable flies, Mucidae, possibly play a role in transmission of Nagana, the animal form of sleeping sickness, and the human disease form. Mechanism. Tryptophan is a chemical compound that induces sleep in humans. It is produced by the trypanosomal parasite in sleeping sickness. Diagnosis: thin blood smear. Microscopic examination of chancre fluid, lymph node aspirates, blood, bone marrow, cerebrospinal fluid. Prevention of regular active surveillance involving detection and prompt treatment of new infections. Tsetse fly control is the backbone of the strategy used to control sleeping sickness. Insecticide, residual spraying, and destruction of tsetse fly habitats. Nursing and midwifery tropical medicine. The current treatment for first-stage disease is intravenous or intramuscular pentamidine for Trypanosoma bruceigambiens. Intravenous serum for Trypanosoma brucei form/kg for 7 days. Second stage. For Trypanosoma brucei intravenous F1-ethine or the combination of nifurtimoxant. F1-ethine appear to be more effective and easier to give. This treatment may replace meloxicam when available, with the combination being first line. Hepatitis. Hepatitis is a condition characterized by inflammation of the liver and is caused by viruses, i.e. hepatitis A, B, C, D. Chronic hepatitis is mainly caused by hepatitis B, C, and D. Patients may be symptomatic or asymptomatic. Virus. Nucleic acids. Wilder. Transmission. Mortality. Risk of. Chronicity. EP. A virus. Unenveloped single. Stranded RNA. Fecal oral route. Low. None. Bet. B virus. Enveloped double. Stranded RNA. Parenteral route. Sexual contact. In utero. High. EP. C virus. Enveloped single. Stranded RNA. Parenteral route. Sexual contact. Close skin contact. Perinatal. Moderately high. Hepatitis D. Virus. Enveloped single. Stranded RNA. Parenteral route. Sexual contact. Perinatal. Fecal oral. Low. None. Chronicity. Depend on. Presence of HPV. Hepatitis E. Enveloped single. Stranded RNA. Fecal oral route. Low. None. Hepatitis A. Hepatitis, formerly known as infectious hepatitis, is an acute infectious disease of the liver, caused by the hepatitis virus HAV. Transmission. It is usually spread by eating or drinking food or water contaminated with infected feces. It may also be spread through close contact with an infectious person. Signs and symptoms. Black small square. Nursing and midwifery tropical medicine. Black small square. 90% of children do not have symptoms. Black small square. Symptoms usually last less than 2 months, although some people can be ill for as long as 6 months. Fatigue. Fever. Abdominal discomfort. Nausea. Loss of appetite. Joint pains. Urticaria. Jaundice, a yellowing of the skin or white to the eyes due to hyperbilirubinemia. Diarrhea. Clay-colored feces. Diagnosis. Serum MIGG again. Alanine transferase enzyme, alt liver enzyme. It is present in blood at higher levels than normal. Blood for HIV hepatitis virus is present in the blood via urine and feces of infected people up to 2 weeks before clinical illness develops. Treatment. There is no specific treatment for hepatitis A. Sufferers are advised to rest, avoid fatty foods and alcohol. These may be poorly tolerated. Eat a well-balanced diet and stay hydrated. Hepatitis B. Hepatitis B is an infectious hepatitis caused by the hepatitis B virus HBV. Transmission. The hepatitis B virus is known as a blood-borne virus because it is transmitted from one person to another via blood or fluids contaminated with blood. Direct contact with blood may occur through the use of dirty needles during illicit drug use. Accidental needle sticks experienced by healthcare workers or contact with blood through other means. Semen, which contains small amounts of blood, and saliva that is contaminated with blood, also carry the virus. The virus may be transmitted when these fluids come in contact with broken skin or a mucous membrane in the mouth, genital organs, or rectum of an uninfected person. Another important route of transmission is from an infected mother to a newborn child, which occurs during or shortly after birth. People who are at an increased risk of being infected. Men or women who have multiple sex partners, especially if they don't use a condom. Nursing and midwifery tropical medicine. People with other sexually transmitted diseases. People who inject drugs with shared needles. People who receive transfusions of blood or blood products. People who undergo dialysis for kidney disease. Institutionalized mentally handicapped people and their attendants, caregivers, and family members. Healthcare workers who are stuck with needles or other sharp instruments contaminated with infected blood. Infants born to infected mothers. Signs and symptoms. Loss of appetite. Feeling tired, fatigue. Nausea and vomiting. Itching all over the body. Pain over the location of the liver on the right side of the abdomen, under the lower rib cage. Jaundice, a condition in which the skin and the whites of the eyes turn yellow in color. Dark urine, the color of cola or tea. Pale color stools, grayish or clay-colored. Symptoms of liver damage may include the following. Fluid retention causing swelling of the belly ascites and sometimes the legs. Weight gain due to ascites. Persistent jaundice. Loss of appetite, weight loss, wasting. Vomiting with blood in the vomit. Bleeding from the nose, mouth, or rectum, or blood in the stool. Hepatic encephalopathy, excessive sleepiness, mental confusion, and in advanced stages. Development of coma. Diagnosis. Hepatitis B antigen anti-HBC. Viral DNA viral load. Liver function tests. Blood for electrolytes if patient has been vomiting a lot. CT scan or ultrasound to detect the extent of liver damage and may also detect cancer of the liver caused by chronic hepatitis B. Liver biopsy may be done to detect the extent of liver damage or to evaluate how well a treatment is working. Other tests may be ordered to rule out other medical conditions. Treatment. Acute hepatitis B usually resolves on its own and does not require medical treatment. Medical treatment. Nursing and midwifery tropical medicine. Medications may also be used to control other symptoms. People with mild symptoms can be cared for at home. Pegylated interferon alpha. It slows the replication of the virus and boosts the body's immune system to fight the infection. Treatment is given for 48 weeks by injection or orally. Nucleoside/nucleotide analogues NAZ, idefovir, entecavir, lamivudine, heptavir, heptadine, telbivudine, and tenofovir. Hepatitis B prevention. Hepatitis B vaccine. If you are sexually active, practice safe sex. Correct use of latex condoms can help prevent transmission of HPV, but even when used correctly, condoms are not 100% effective at preventing transmission. Men who have sex with men should be vaccinated against both hepatitis and hepatitis B. If you inject drugs, don't share needles or other equipment. Don't share anything including grooming products that might have blood on it, such as a razor, toothbrush, fingernail clippers, etc. Healthcare workers should follow standard precautions and handle needles and sharps safely. Hepatitis C. It belongs to the class of viruses called flaviruses. Route of transmission. Parenteral route. Close body contact through body fluids. Intravenous drug abuse. Sexual contact. Mother-to-child transmission. Traditional administration of medicines/practices that involves cutting of skin. Clinical features. Mostly asymptomatic. Symptoms are generally mild and vague. Decreased appetite. Fatigue. Nausea. Muscle or joint pains. Weight loss and rarely does acute liver failure result. Chronic infection. Nursing and midwifery tropical medicine. Or HCV or in a polymerase chain reaction PCR viral load. Or biopsy to determine the degree of liver damage. Treatment. Black small square. Combination of interferon alpha and ribavirin for a period of 24 or 48 weeks. Black small square. Sofosbuvir with ribavirin and interferon. Black small square. Surgery liver transplantation. Prevention. No vaccine available at the moment. Control from infections. Proper disposal of hospital waste. Reducing parenteral injections. Hepatitis D HCV. Hepatitis D is a disease caused by a small circular enveloped RNA virus. Transmission. The routes of transmission of hepatitis D are similar to those for hepatitis B. Infection is largely restricted to persons at high risk of hepatitis B infection, particularly injecting drug users and persons receiving clotting factor concentrates. Treatment and prevention. Other vaccine for hepatitis B protects against hepatitis D virus because of the latter's dependence on the presence of hepatitis B virus for it to replicate. O-interferon alpha can be used in reducing the severity of the infection. Hepatitis E. Hepatitis E is a viral hepatitis caused by infection with a virus called hepatitis E virus HEV. Transmissioner. It is spread mainly by the fecal-oral route due to fecal contamination of water supplies or food, though person-to-person transmission is uncommon. Signs and symptoms. Black small square. The incubation period of hepatitis E varies from 3 to 8 weeks. Black small square. Jaundice. Black small square. Fatigue. Black small square. Nausea. Black small square. Anorexia. Black small square. Abdominal pain. Diagnosis. Nursing and midwifery tropical medicine. Prevention. Improving sanitation is the most important measure in prevention of hepatitis E. Vaccination. Treatment. There is no specific treatment for acute hepatitis E infection. Ribavirin or a combination of ribavirin and peginterferon. Supportive treatment. Haemophilus influenzae. Haemophilus influenzae type B is a gram-negative bacterium that causes meningitis and acute respiratory infections, mainly in children. Cause: Haemophilus influenzae diseases Bacterium Haemophilus influenzae. Transmission: Haemophilus influenzae bacteria live normally in the upper respiratory, nose and throat tract of most healthy people without causing illness. Habe disease is spread mainly through person-to-person contact with infected droplets coughing or sneezing or discharges from an infected person's nose and throat. Incubation period: The incubation period is unknown, but is probably less than 1 week. Symptoms and signs: Clinical features may include initial symptoms of inertia. Associated fever is low grade. Cough with greater creamy sputum. Severe headache. Difficulty with breathing with wheezing. Stiff neck. Convulsions or seizures. Severe drowsiness. Difficulty waking up. Loss of consciousness. A range of other infections caused by Haemophilus influenza. Meningitis, an infection of the membrane covering the brain. Signs include fever, stiff neck, drowsiness, irritability, and refusing food. Epiglottitis, inflammation of the flap at the top of the windpipe epiglottis, which can block a child's breathing. Signs can include severe breathing difficulties, fever, restlessness, and irritability. Pneumonia, lung inflammation. Symptoms include fever, cough, chest pains, and breathing. Nursing and midwifery tropical medicine. Septic arthritis joint infection. Symptoms include joint pain, swelling, and reduced mobility of the joint. Cellulitis, infection of the tissue under the skin, usually on the face. These conditions can develop very quickly. If left untreated, the child could die very rapidly. Diagnosis: Since other types of bacteria can cause similar infections, it is important to test specifically for the presence of Haemophilus influenzae type B. Physical examination: Blood for culture. Cerebrospinal fluid CSF for culture. Other specimens for immunological tests. Treatment: Depending on the illness, treatment may include admission to hospital, a course of the appropriate antibiotics such as cefotaxime, ceftriaxone, or ampicillin with chloramphenicol are generally used to treat serious infections. Rifampin is used in some circumstances as preventive treatment for persons who have been exposed to Hib disease. A child with epiglottitis may be cared for in an intensive care unit and a breathing tube inserted to help them breathe. Nursing and midwifery tropical medicine. Ebola virus disease (EVD). Ebola virus disease or Ebola hemorrhagic fever (EHF) is the human disease which may be caused by any of 4 of the 5 known Ebola viruses. The name comes from the Ebola River in the Democratic Republic of the Congo, where it was first found. Cause: Ebola virus. The 5 characterized Ebola species are Zaire Ebola virus. It has the highest case fatality rate of the Ebola viruses, up to 90%. The first outbreak occurred on 26 August 1976 in Yambuku. The first recorded case was Mablo Loka, a 44-year-old school teacher. Sudan Ebola virus. Like the Zaire virus, the Sudan Ebola virus emerged in 1976. It was at first assumed to be identical with the Zaire species. Côte d'Ivoire Ebola virus. Also referred to as Thai forest Ebola virus, it was first discovered among chimpanzees from the Thai forest in Côte d'Ivoire, Africa in 1994. Bundibugyo Ebola virus. Ebola virus was first confirmed in Bundibugyo district on 24 November 2007. Nursing and midwifery tropical medicine. It was discovered during an outbreak of simian hemorrhagic fever virus SHFE in crab eating macaques from Heselton Laboratories, now Covens, in 1989. Transmission. Ebola virus is transmitted to a human via contact with an infected animal host. Human-to-human transmission occurs via direct contact with blood or bodily fluids from an infected person, by contact with contaminated medical equipment such as needles. Because bodies of the deceased are still infectious, measures have to be taken to properly dispose of dead bodies in a safe manner despite local traditional burial rituals. Signs and symptoms. The incubation period is about 2-12 days, but can be as long as 25 days. Ebola virus disease begins with a sudden onset of an influenza-like stage characterized by general malaise, fever with chills, arthralgia, myalgia, and chest pain. Nausea is accompanied by abdominal pain, anorexia, diarrhea, and vomiting. Respiratory tract involvement is characterized by pharyngitis with sore throat, cough, dyspnea, and hiccups. The central nervous system is affected as judged by the development of severe headaches, agitation, confusion, fatigue, depression, seizures, and sometimes coma. Cutaneous presentation may include maculopapular rash, petechiae, purpura, ecchymosis, and hematomas, especially around needle injection sites. Bleeding from mucous membranes and puncture sites is reported in 40–50% of cases. Sources of bleeds include hemimesis, hemoptysis, melena, and bleeding from mucus. Membranes of nose, vagina, and gingiva. Development of hemorrhagic symptoms is generally indicative of a negative prognosis. Death occurs due to fluid redistribution, hypotension, disseminated intravascular coagulation, and focal tissue necrosis. Nursing and midwifery tropical medicine. Blood or serum for Ebola antigen. RT-PCR reverse transcription polymerase chain reaction. Treatment. There is currently no approved Ebola virus-specific therapy for EVD. Treatment is primarily supportive in nature and includes strict isolation to prevent spread of infection, minimizing invasive procedures, balancing fluids and electrolytes to counter dehydration, administration of anticoagulants early in infection to prevent or control disseminated intravascular coagulation, administration of procoagulants late in infection to control hemorrhaging, maintaining oxygen levels, pain management, administration of antibiotics or antimycotics to treat secondary infections. Prognosis. Prognosis is generally poor. Average case fatality rate of all outbreaks to date equals 68%. If a patient survives, recovery may be prompt and complete. Some Ebola viruses are known to be able to persist in the sperm of some survivors, which could give rise to secondary infections and disease via sexual intercourse. Prevention. Ebola viruses are highly infectious as well as contagious. The bodily fluids from diarrhea, vomiting, and bleeding should strictly be disinfected. Stop all needle sharing or use without adequate sterilization procedures. Sterilization of all used instruments. No visitors should be allowed in isolated areas. Strict quarantine of all suspected people. No movement is allowed. In endemic zones, the avoidance of risk factors, such as contact with non-human primate or bats, is highly recommended. During outbreaks, avoid direct skin-to-skin contact with patients, their excretions and body fluids, or possibly contaminated materials and utensils. Nursing and midwifery tropical medicine. Patients should be isolated and medical staff should be trained and apply strict barrier nursing techniques, disposable face mask, gloves, goggles, and a gown at all times. Traditional burial rituals, especially those requiring embalming of bodies, should be discouraged or modified, ideally with the help of local traditional healers. Laboratory researchers have to be properly trained and wear proper personal protective equipment. Avoid sexual intercourse. Marburg hemorrhagic fever. Marburg hemorrhagic fever is a rare, severe type of hemorrhagic fever which affects both humans and non-human primates. Cause. It is caused by a zoonotic, that is, animal-borne or RNA virus of the filovirus family. Risk factors. Laboratory or quarantine facility workers who handle non-human primates that have been associated with the disease. Hospital staff and family members who care for patients with the disease are at risk if they do not use proper barrier nursing techniques. Transmission. Marburg can be transmitted through contact with body fluids of an infected person. Droplets of body fluids, or direct contact with persons, equipment, or other objects contaminated with infectious blood or tissues are all highly suspect as sources of disease. Signs and symptoms. Black small square. The incubation period of Marburg is 5 minutes 10 days. Black small square. The onset of the disease is sudden and is marked by fever, chills, headache, and myalgia. Black small square. Around the 5th day after the onset of symptoms, a maculopapular rash, most prominent on the trunk, chest, back, stomach, may occur. Black small square. Nausea, vomiting, chest pain, a sore throat, abdominal pain, and diarrhea that may appear. Black small square. Symptoms become increasingly severe and may include jaundice, inflammation of the pancreas, severe weight loss, delirium, shock, liver failure, massive hemorrhaging, and multi-organ dysfunction. Diagnosis. Antigen capture enzyme linked to immunosorbent ELISA testing, IgM capture, ELISA. Polymerase chain reaction, PCR. Complications. 1. Orchitis. Nursing and midwifery tropical medicine. Treatment. A specific treatment for this disease is unknown. Supportive treatment. Balancing the patient's fluids and electrolytes. Maintaining their oxygen status and blood pressure. Replacing lost blood and clotting factors. Treating PTS for any complicating infections. Prevention. As for Ebola hemorrhagic fever. Filariasis. Filariasis is a parasitic disease that is caused by thread-like roundworms. These are spread by blood-feeding black flies and mosquitoes. Types. Lymphatic filariasis is caused by the worms Wucheria bancrofti, Ferruginale, Burgittimori. These worms occupy the lymphatic system, including the lymph nodes. In chronic cases, these worms lead to the disease elephantiasis. Subcutaneous filariasis is caused by Lolo the eye worm, Mensonella streptosica, Onchocerca volvulus. These worms occupy the subcutaneous layer of the skin in a fat layer. Lolo called as Loa. Filariasis, while Onchocerca volvulus causes river blindness. Serous cavity filariasis is caused by the worms. Mensonella postans. Nursing and midwifery tropical medicine. The most spectacular symptom of lymphatic filariasis is elephantiasis edema with thickening of the skin and underlying tissues. Elephantiasis results when the parasites lodge in the lymphatic system. Elephantiasis affects mainly the lower extremities. Different species of filarial worms tend to affect different parts of the body. Widgery bancroft can affect the legs, arms, vulva, breasts, and scrotum, causing hydrosol formation. Brugita more rarely affects the genitals. Other subcutaneous worms present with skin rashes, urticarial papules, and arthritis, as well as hypopigmentation. Onchocerca volvulus manifests itself in the eyes, causing river blindness. Onchocercasis. Serous cavity filariasis presents with symptoms similar to subcutaneous filariasis, in addition to abdominal pain. Diagnosis: thin and thick blood film smears, finger prick test. Blood must be drawn at appropriate times, which reflect the feeding activities of the vector. Insects. Examples are W. bancrofti, whose vector is a mosquito. Night is the preferred time for blood collection. Lolo's vector is the deerfly. Daytime collection is preferred. Skin snip/biopsy for M. streptosica. O. volvulus. Tests are done anytime. Polymerase chain reaction PCR and antigenic assays, which detect circulating filarial antigens. Lymph node aspirate. Medical imaging, such as CT or MRI, and X-ray tests can show calcified adult worms and lymphatics. Nursing and midwifery tropical medicine. Doxycycline for 8 weeks. Scabies. Scabies from Latin, scaba, to scratch, is a contagious skin infection caused by the mite Sarcops scabiei. The mite is a tiny parasite which burrows under the host skin, which in most people causes an intense itching sensation caused by an allergic response. Transmission. Black small square. Scabies is contagious and can be spread by scratching an infected area, thereby picking up the mites under the fingernails. Black small square. The disease is transmitted by direct skin-to-skin contact, with a higher risk with prolonged contact, e.g., in bed, contact between children while playing. Black small square. Transmission is also possible indirectly through sharing clothes. Black small square. Scabies can be transmitted through sexual intercourse even if a latex condom is used, because it is transmitted from skin to skin at sites other than sex organs. Black small square. Though socioeconomic conditions favor the spread of the disease. Epidemiology. Scabies is one of the 3 most common skin disorders in children, along with tinea and pyoderma. It affects approximately 100 million people, 1.5% of the world population. Common in both sexes. Signs and symptoms. The characteristic symptoms of a scabies infection include nursing and midwifery tropical medicine. There may be a secondary bacterial infection. Blisters and pustules on the palms and soles of the feet are characteristic symptoms of scabies in infants. Life cycle of scabies. Sarcops scabiei mite are under 0.5 mm in size, but are sometimes visible as pinpoints of wet. Pregnant females tunnel into the dead outer mosaic stratum corneum of a host skin and deposit eggs in the shallow burrows. The eggs hatch into larvae in 3 to 10 days. These young mites move about on the skin, leave the parents' tunnel, and bury themselves in the skin elsewhere but do not make tunnels. The movement of mites within and on the skin produces an intense itch. Diagnosis. A magnified view of a burrow and trail of the scabies mite. Clinically in geographical areas where it is common when skin scraping for microscopy. Using dermoscopy to examine the skin directly. Management. Permethrin is the most effective treatment for scabies and is the treatment of choice. It is applied usually before bedtime and left on for about 8 to 14 hours, then washed off in the morning. Options to control itchiness include antihistamines. Ivermectin is effective in eradicating scabies, often in a single dose. Other treatment includes benzobenzo, malathion, and sulfur preparations. Soap and water is an alternative treatment. Nursing and midwifery tropical medicine. Pediculosis. Pediculosis is an infestation of the scalp, hairy parts of the body or clothing with lice, blood, feeding parasites in their larvae or eggs. Classification. Pediculosis may be divided into the following types. Pediculosis capitis head lice infestation. Feticulosis corporis caused by body lice. Feticulosis pubis crabs. Transmission. It is usually transmitted directly by person-to-person contact. It may also be transmitted via clothing, towels, and beddings of an infected person. Life cycle. The female parasite produces several hundreds of eggs daily, each of which is attached to the air, with a special glue which makes it very difficult to remove. Add lice pediculus humanus capitis. Presentation. Head lice infestation is most frequent on children aged 3 to 10 and their families. Visible lice are in nets on scalp. Lice feed on blood once or more often each day by piercing the skin with a tiny needle. Like mouth parts. While feeding, they excrete saliva, which irritates the skin and causes itching. Excessive scratching of the infested areas can cause sores. Nursing and midwifery tropical medicine. Causes. Body lice live in the seams and folds of clothing. They feed on human blood and lay their eggs and deposit waste matter on the skin and clothing. They can live in clothing for up to 1 month. Lice die within 5-7 days at room temperature if they fall off a person. You can catch body lice if you come in direct contact with someone who has lice. You can also get lice from infected clothing, towels, or bedding. Body lice are bigger than other types of lice. You are more likely to get body lice if you do not bathe and wash your clothes often or lie in close overcrowded conditions. Lice are unlikely to last if you. Symptoms. Lice causes severe itching. Itching is usually worse around the waist, under the arms, and places where clothing is tighter and closer to the body, such as near bra straps. You may have red bumps on your skin. The bumps may scab or become crusty after scratching. Skin around the waist or groin may become thickened or change color if you have been infected with lice in that area for a long time. Pubic lice. The pubic or crab lice Pithorus pubis are very small insects that infest the genital area. Pubic lice are distinct from body and head lice and are often smaller in size. Lice feed on human blood and cause intense itching in affected areas. Transmission. Pubic lice are transmitted through intimate contact, usually sex. It's also possible to catch pubic lice from using the blankets, towels, sheets, or clothing of people contaminated with pubic lice. Life cycle. The adult louse lays its eggs on the hair shaft near the skin. These eggs are called nits. 7 to 10 days later, the nit hatches into a nymph. Then it starts feeding on your blood. The lice can live without feeding on blood for a day or two. Signs. While some people have no symptoms, it's more likely that your genitals and or anus will start itching about 5 days after the initial infestation. At night, the itching becomes more intense. Low-grade fever. Irritability. Lack of energy. Pale blue spots near bites. Management. Shave the affected area. Chemical treatments. Malathion works by paralyzing and killing the lice and their eggs. Nursing and midwifery tropical medicine. Lindane shampoo, it kills the lice but not their eggs, so retreatment is essential. Paint the affected body surface with benzoate applications, 25% 12 hourly. Chlorotamitin applied twice in 24 hours. This should be washed after 24 hours. Treat all household contacts. Body lice mainly live in clothing. To get rid of lice, destroy infected clothing but carefully. Wash items in hot water at least 130 degrees F, then machine dry using a hot cycle. Bathing and washing clothes, bedding, and towels are most important steps in treating lice. Prevention. Health education on improving personal hygiene, regular bathing. Washing of clothes, bedding. Avoid sharing clothes/beddings. Avoid sexual contact with infested persons. Treatment of infested persons. Case finding. Tungiosis jiggers. Tungiosis is an inflammatory skin disease caused by infection with the female parasitic Tunga penetrans flea, also known as jiggle flea, jigger, Nikki or sand flea. Tunga penetrans is the smallest flea in the world, measuring 1 mm across. Symptoms. The symptoms of this disease include severe pruritus, pain, inflammation and swelling, lesions and ulcerations with black dots in the center. If left untreated, secondary infections such as bacteremia, tetanus, and gangrene can occur. Life cycle. Black small square. The larva will hatch from the egg within 1 to 6 days, assuming environmental conditions e.g. moisture, humidity, etc. are favorable. Black small square. About 6 to 8 days after hatching, the larva pupa's larva develops into pupa and builds a cocoon around itself. Black small square. Because it lives mostly on and below the surface of sand, sand is used to stabilize the cocoon and help to promote its development. Black small square. An environmental disturbance such as rain or a lack of sand decreases the incidence, most likely due to decreasing the environmental factors, i.e., then on which the flea depends for overall growth. Black small square. If there are no disturbances to the cocoon, an adult flea will emerge from the pupa stage after 9-15 days. Nursing and midwifery tropical medicine. There are no diagnostic tests for Tengiasis. This is most likely because the parasite is ectoparasitic with visible symptoms. Management. Black small square. Mechanical removal of parasites with a sterile pin. Black small square. Formaldehyde, chloroform, or DDT can be used topically to kill and suffocate the flea. Black small square. Vaseline will kill the organism as well. Black small square. Even without treatment, the burrowed fleas will die within 5 weeks and are naturally sloughed off as the skin sheds. Black small square. Antiseptic dressing to prevent secondary infection. Black small square. Antibiotic to prevent secondary infection. Fungal infections. Dermatophytosis, fungal skin infections. Dermatophytosis is a clinical condition caused by fungal infection of the skin in humans. Several types are identified according to cost of organisms, site, and clinical features. Classification of fungal infections. Superficial fungal infections. Deep fungal infections. Cause. Fungal skin infections are superficial infections caused by dermatophytes fungi, which invade dead tissue of the skin and its appendages, i.e., stratum corneum, nails, hair, e.g., athlete's foot, ring, worms. Characteristics. The study of fungi is called mycology. All fungi are eukaryotic microorganisms. All they require organic compounds, energy, and carbon. All they are aerobic or facultative anaerobes. Almost fungi are saprophytes in soil and water. Superficial fungal infections. Dermatophytes, these are fungi that have the ability to live on keratin hair, nails, or skin of an animal. Types common causative agents. Trichophyton. Nursing and midwifery tropical medicine. Epidermophyton. These fungi attack various parts of the body and lead to the conditions listed below. Tinea athlete foot affects the fetor. Tinea unguim affects the fingernails and toenails. Tinea corporis affects the arms, legs, and trunk. Tinea cruris jokic affects the groin area. Tinea manuum affects the hands and palm area. Tinea capitis affects the scalpel. Tinea barbae affects facial hair. Tinea faciae face fungus affects the face. Other superficial mycosis not classic ringworm, since not caused by dermatophytes. Tinea versicolor caused by Malassezia furfura. Tinea nigra caused by Hertia wernickeae. Signs and symptoms. Infections on the body may give rise to typical enlarging raised red rings of ringworm. Infection on the skin of the feet may cause athlete's foot. The groin jock itch. Involvement of the nails is termed onychomycosis, and they may thicken, discolor, and finally crumble and fall off. Dermatophytosis tends to get worse during summer, with symptoms alleviating during the winter. Animals such as dogs and cats can also be affected by ringworm, and the disease can be transmitted between animals and human zoonotic disease. Prevention. Avoid sharing clothing, sports equipment, towels, or sheets. Washing clothes in hot water with fungicidal soap after suspected exposure to ringworm. Avoid walking barefoot, instead wear appropriate protective shoes and sandals. After being exposed to places where the potential of being infected is great, one should wash with an antibacterial and antifungal soap. Avoid touching pets with bald spots, as they are often carriers of the fungus. Treatment. Antifungal treatments include topical agents such as meconazole, terbinafine, clotrimazole, ketoconazole, tonoftate. These are applied twice daily until symptoms resolve, usually within 1 or 2 weeks. Topical treatment should then be continued for a further 7 days after a resolution of visible symptoms to prevent recurrence. The total duration of treatment is therefore generally 2 weeks, but may be as long as 3. Nursing and midwifery tropical medicine. Antifungal agents. Class. Examples. Mode of action. Antibiotics. Bricifulvin. Binds to tubulin, interfering with microtubule function, thus inhibiting mitosis. Polyene antifungal. Agents. Amphotericin B. Nicotin. Candicidin. Natomycin. Azoles. Clotrimazole. Iconazole. Ketoconazole. Miconazole. Fluconazole. Itraconazole. Turconazole. Abafangina. Inhibit cell metabolism. Inhibit production of ergosterol by inhibiting lenosterol. Allylamines. Terbinafine. Butanafine. Inhibits production of ergosterol by inhibiting squalene epivote. Deep fungal infections. Deep fungal infections are also called systemic mycosis. The commonly isolated organisms are that Candida albicans, Candidiasis. Cause: Candidiasis is caused by Candida albicans. Sites affected: O mouth oral candidiasis, oral thrush. O esophagus esophageal candidiasis. O vagina vaginal candidiasis. O nail onychomycosis. Classification: Candidiasis may be divided into the following types: mucosal candidiasis, oral candidiasis thrush, oropharyngeal candidiasis, candidal vulvovaginitis vaginal yeast infection, candidal balanitis, infection of the gland penis, almost exclusively occurring in uncircumcised males, or esophageal candidiasis candidesophagitis, cutaneous candidiasis, candidal intertrigo cause inflammation of two superficial skin fossa, candidal paronychic cause inflammation of nail fossa, perineal candidiasis affects the perineum, or nursing and midwifery tropical medicine, onychomycosis nail infection caused by candida, invasive candidiasis, systemic candidiasis one organ system involvido, disseminated candidiasis multisystem involvement e.g. hepatosplenic, candidiasis which sometimes follows neutropenia or candidemia, a form of septicemia. Clinical presentation: symptoms of candidiasis vary depending on the area affected. Black small square most candida infections result in minimal complications such as redness, itching, and discomfort. Black small square candida infections can affect the esophagus, causing dysphagia, difficulty swallowing / odonophagia, painful swallowing, epigastric pain, diarrhea, vomiting. Black small square infection of the vagina or vulva may cause severe itching, burning, soreness, irritation, whitish or whitish-grey cheese-like discharge, often with a cud-like appearance. Black small square. Symptoms of infection of the male genitalia balanitis thrush include red skin around the head of the penis, swelling, irritation, itchiness, soreness of the head of the penis, thick discharge under the foreskin, unpleasant odor, difficulty retracting the foreskin phimosis, pain when passing urine or during sex. Black small square. Perineal candidiasis can cause pruritus ani. The lesion can be erythematous, papular, ulcerative in appearance. Diagnosis: black small square. Microscopic examination: nursing and midwifery tropical medicine. A localized infection: fluconazole is effective in treating a vaginal yeast infection. Local treatment may include vaginal suppositories or medicated douches. Gentian violet can be used for thrush and breastfeeding babies. For vaginal yeast infection in pregnancy, topical imidazole or triazole antifungal is considered the therapy of choice, but can also be treated using nystatin pessaries or gentian violet 1% into the vagina. O blood infection and candidial infections of the blood, intravenous fluconazole or an echinocandin such as caspofungin may be used. Amphotericin B is another option, though paronychia is treated using grisofulvin 500 mg daily for 6 weeks. O nursing care. Good personal hygiene. Prevention. Black small square. Early detection and treatment. Black small square. Vaginal candidiasis, avoid unprotected sexual intercourse. Black small square. Good personal hygiene. Black small square. Avoid external use of detergents and douching. Mumps. Mumps epidemic pertitis is a viral disease of humans caused by the mumps virus. Cause: O mumps virus. Mode of spread: mumps is a contagious disease that is spread from person to person through contact with respiratory secretions, such as saliva from an infected person. When an infected person coughs or sneezes, the droplets can enter the eyes, nose, or mouth of another person. Mumps can also be spread by sharing food and drinks. The virus can also survive on surfaces and then be spread after contact in a similar manner. The incubation period can be from 16-18 days. Signs and symptoms: swelling of salivary glands, cheeks, painful salivary glands, fever, headache. Diagnosis: our physical examination confirms the presence of the swollen glands. A polymerase chain reaction PCR. Prevention: nursing and midwifery tropical medicine. The vaccine is routinely given to children at age 13 months with a booster at 3-5 years per school. This confers lifelong immunity. Black small square. Infection prevention and control, general precautions. Treatment: there is no specific treatment for mumps. Symptoms may be relieved by the application of intermittent ice or heat to the affected neck/testicular area. Acetaminophen/paracetamol for pain relief. Warm salt water gargles. Eat soft foods. Extra fluids may also help relieve symptoms. Patients are advised to avoid acidic foods and beverages, since these stimulate the salivary glands, which can be painful. Risk. Complication. Males past puberty who develop mumps have a 15-20% risk of orchitis, painful, inflammation of the testicles. Typhus fever. It is an infection caused by rickettsia. It causes our epidemic louse-borne typhus fever caused by Rickettsia prowazekii, which is transmitted to man by lice. Murine typhus fever caused by Rickettsia typhi and is transmitted by rat fleas. Rats and mice are reservoirs. Scrub typhus fever mole-borne typhus caused by Rickettsia tsutsukimashii and transmitted by rodent mites. Clinical features: headache, fever, chills, general body pains, severe weakness, macular rash which appears on the 5th day post-infection. Nursing and midwifery tropical medicine. Malaria. Investigations. Blood for Felix reaction. Management. Caps doxycycline 112 hourly for 5 to 10 days or TOM/KG/WT. Chloramphenicol 15/KG6 for 7 to 10 days. Prevention. Good personal hygiene. Destruction of lice and rodents. Food poisoning. It is a term used applied to an acute intestinal disease acquired by the consumption of water or food. Intoxicated with chemicals e.g. heavy metals, fluorine, or toxins produced by bacteria. It may occur as an outbreak but commonly affects people who share the same source of infection, e.g. eating from the same meal or drunk same water. It may be limited to a home or a function, e.g. funeral or wedding or social event. Common causes. Staphylococcus occurs in 1-6. Salmonella occurs in 12-14. Clinical features: acute onset, vomiting, diarrhea, abdominal pain, fever and chills, convulsions, hemoptysis. Nursing and midwifery tropical medicine. Stool culture, blood culture, management. Correcting dehydration is the mainstay of treatment. Intravenous expen or intravenous ceftriaxone or ciprofloxacin plus metronidazole. Prevention. Serve food when hot. Avoid eating cold leftover food. Screen food handlers. People with staphylococcal skin infection should not be allowed to handle food. Keep a clean kitchen.